Greetings and good day to everyone, or night from my part of the world. I'm very pleased to be here with you tonight. I greet you for Singapore as we begin the third and final webinar organized in partnership between I and Celine dedicated to osteoporosis. Allow me to introduce myself. I'm Dr. Vivian Lim. I sit on the board of the International Society of Endocrinology, and I'm also the chairperson of the educational working group of the society. To ensure success of these sessions from a logistical standpoint, I would like to mention some technical guidelines. To keep turned off microphones and cameras all the time. There shall be simultaneous English-Spanish translations which are available, and they can be accessed via the globe icon so you can listen into the language of your choice. We shall address the questions you submitted in advance during registration and also invite you to write your questions in English or Spanish during this broadcast in the chat at the bottom of your screen. Certificates of participation will be issued for this and each of the following webinars. Our streaming team will verify attendance at the end of each event. Each webinar will be broadcast live on Celine's YouTube and Facebook channel and will also remain available on demand on Celine's website and on ICE Education Hub. With the logistical issues out of the way, it takes me great pleasure then to hand the floor to Dr. Claudia Campuzano from Chile, with whom I shall be co-hosting this event. Dr. Claudia, over to you.
Thank you very much, Vivian. Thank you for this invitation. And good day for everyone. I'm here in Santiago de Chile. And I'm very pleased to introduce our speaker today. He's Professor Michael McClung. With almost 50 years of experience, Dr. McClung, the founder director of the Oregon Osteoporosis Center, is an international recognized expert in the management of patients with osteoporosis, conducting and reporting clinical trials and educating young physicians about managing bone health. The title of his talk today is a global overview of currently available osteoporosis treatment. Please remember that you can send your question in the chat. And I want to welcome my very good friend, Mike McClung.
Hello, I'm Dr. Michael McClung from the Oregon Osteoporosis Center in Portland, Oregon. I'm very pleased to be a part of this osteoporosis series sponsored by Phalian and the ICE. I want to thank the organizing committee, particularly Drs. Vivian Lin and Dr. Claudia Campuzano, for allowing me to be a part of this interesting program. Today, I would like to present a global overview of the currently available treatments for osteoporosis. Note my disclosures at the bottom of the slide. I receive support from Amgen for various things and am a member of the board of the International Osteoporosis Foundation. To begin, let's remind ourselves that osteoporosis is a disorder characterized not only by low bone density, but also by deteriorated bone microarchitecture. And it is that deteriorated architecture that most importantly impairs bone strength and increases the risk of fracture. Women experience bone loss beginning a few years before menopause. There is an interval of relatively rapid bone loss across the menopausal transition, and then a more gradual loss of bone density through the remainder of the woman's life. On average, in the United States, a woman who comes to menopause with an average bone density value reaches the threshold where we diagnose osteoporosis by about age 82. For women who come to menopause with lower bone density, they are destined to develop osteoporosis earlier in life, and these may be appropriate candidates for therapy to prevent that bone loss and to prevent osteoporosis. Like other chronic diseases, treating osteoporosis requires long-term management. We know that at least 6.8% of American women between the ages of 50 and 59 already have osteoporosis by bone density criteria, and for them, very long therapy will be required. None of our current therapies cures osteoporosis. We use bone building drugs only for 1 to 2 years because of the waning anabolic effect of those agents, and the effects of all of our osteoporosis therapies, including bisphosphonates, dissipate at various rates when treatment is stopped. So, long-term, if not lifelong, management of patients with osteoporosis is required. For treating those patients who have osteoporosis, the objective is to improve their bone strength, to reduce fracture risk, and we do that in patients that we identify as being at high risk of fracture. As you're aware, the drugs we have fall into two major categories: anti-remodeling drugs, often called anti-resorptive drugs, that includes bisphosphonates, the estrogen agonist, and denosumab, the rank ligand inhibitor. These drugs reduce bone resorption, but they also reduce bone formation. And as a consequence, they may stabilize bone structure, but they are not capable of improving or restoring bone structure back to normal. On the other hand, the bone forming or osteoanabolic agents increase bone formation. They have varying effects on bone resorption, but they are capable of restoring the disordered bone microarchitecture back toward normal. With our menu of treatment options, we are now aware that no single drug is appropriate for therapy for a person's lifetime. Optimal management involves the use of different drugs in various sequences. And at the end of any sequence, the final step, I believe, is what I will call intermittent bisphosphonate maintenance therapy that we will address later. So as we think about the lifetime management of patients, we begin that journey by deciding who to treat and how to begin the initial therapy. So a patient at high risk of fracture is identified. There are various criteria that different guidelines have, including low bone density, previous, especially recent fractures, or multiple fractures, or combinations of risk factors that place patients at high fracture risk. To choose the initial therapy, there are several ways we could go about that. Firstly, we could use a strategy common in other diseases, so-called step therapy that I'll describe, or we could employ the newly described goal-directed therapy approach, or we could simply base the initial therapy on our assessment of the patient's fracture risk at the time they're seen. Step therapy is used commonly in other chronic disorders like diabetes and hypertension, where treatment is often started with an inexpensive, less effective drug, and then if the result is not what we want, we can either add other drugs or switch to more effective drugs. That strategy, however, does not work with osteoporosis drugs for the following reasons. Firstly, with the possible exception of combining osteoanabolic agents with denosumab, the effect of combining different treatments is typically not superior to sequential monotherapy. Secondly, and more importantly, the bone density response to all of our potent therapies, including denosumab and the osteoanabolic agents, is blunted when used after an anti-remodeling drug. The graph shows data looking at changes in lumbar spine and total hip bone density in response to denosumab, to teriparatide, and to romosozumab in patients who were treatment naive, shown in the white bars, after bisphosphonate therapy, shown in the gold bar, or after denosumab, shown in the blue bar. And no matter how we look at that, patients who were previously treated with either bisphosphonates and especially denosumab have a smaller response to our more important therapies. So the optimal effects of our best osteoporosis agents are seen when they are used as the initial therapy rather than as second-line therapy. The goal-directed therapy idea is still evolving as a concept, but is supported by studies shown here. On the left are data from the SABRE study from the Foundation for the NIH, in which it was shown that drugs that induced the largest changes in bone density were associated with the greatest reductions in fracture risk. In support of that, the data on the right looks at the relationship between on-treatment total hip bone density achieved, in this case with denosumab therapy, and the incidence of non-vertebral fracture in the year subsequent to that bone density test. As you see, the higher the on-treatment total hip bone density, the lower the risk of fracture, up to a point where it seems that perhaps beyond a t-score of -2, there is little additional benefit. Similar data have been seen with romosozumab and with alendronate. So the concept of goal-directed therapy is to choose a practical clinical target, and the optimal target we believe currently is a total hip t-score. And we choose that target that predicts or is correlated with our major outcome, in this case, fracture risk reduction. And then for each patient, we choose both the initial and subsequent treatments based on the probability of achieving that target. So again, a total hip, a t-score target of at least -2.5, or ideally, perhaps even better, of -2.0 would be the appropriate target. We've seen an example of that in Dr. Libanati's presentation previously. I'll just remind us of that, the probability of having a patient with a t-score of -3 reach a total hip t-score of -2.5 within 3 years of treatment is shown with 3 different approaches. Alendronate only, where the probability is very low, only 9.3%. Romosozumab followed by alendronate, where the probability is 38%, or our most effective combination therapy of romosozumab followed by denosumab, where the probability is 61%. So we can employ this idea in making those treatment decisions. And finally, current guidelines suggest that we make the initial treatment choices based upon the patient's fracture risk. The American Association of Clinical Endocrinology, as an example, suggests that for patients at high risk of fracture, this would be anyone who meets the treatment criteria, that the recommended therapies would be potent anti-remodeling drugs, bisphosphonates, or denosumab. Whereas for patients at very high risk, those with recent or multiple fractures, fractures on therapy, very low bone density, or high fracture probability by fracs, then they recommend that the osteoanabolic agents be considered as the initial therapy. Let's make some comments about those recommendations. We are very familiar with bisphosphonate therapy, the most commonly used drugs, both because they were the first and now are the least expensive approaches to treatment. Significant reductions in vertebral, non-vertebral, and hip fractures are seen with therapy, and but the increase in bone density and the fracture risk reduction with bisphosphonates reaches a plateau after 3 to 5 years of therapy, as seen in the data shown on the right with the long-term zoledronate study. There is no incremental benefit of continuing a bisphosphonate for more than 5 years at a time. For patients who, after 3 to 5 years of therapy, are thought to be at low risk of fracture, we consider a temporary interruption of therapy called the bisphosphonate holiday. However, for patients who continue to be at high risk, it's recommended that treatment be continued. If they continue on a bisphosphonate, again, there's no improvement in their fracture risk, but they are subjected to a duration-related increasing risk of atypical femoral fracture. Given that, it's my thought that there is no justification for the use of continuous bisphosphonate therapy for more than 5 years at a time. And for patients remaining at high risk of therapy after 3 to 5 years of bisphosphonates, we should consider switching to another therapy. The story is different with denosumab. Over 10 years, bone density progressively increased and nonverbal fracture rates decreased the longer the patients were on treatment, and there were no duration-related adverse events, leading me to believe that there is no limit to the duration of denosumab therapy. Certainly, we should not consider a drug holiday in these patients. There is no evidence of loss of effectiveness with long-term use, and as I mentioned, no duration-related adverse events. But if therapy is discontinued, steps must be taken to prevent or to limit the expected rebound in bone remodeling and the rapid loss of fracture protection. After short-term therapy, the European Calcified Tissue Society suggests that patients transition to alendronate for 2 years or to receive 1 dose of zoledronate. However, for patients who have been on denosumab for a longer time, it is more difficult to control that rebound in remodeling, and it's recommended that patients receive a dose of zoledronate 5 to 6 months after the last dose of denosumab, and then if CTX is available, that we monitor this index of bone resorption at 3 and 6 months after the dose of zoledronate, and to give another dose if CTX is above the median of the premenopausal CTX range. If CTX is not available, then additional doses of zoledronate 6 to 12 months after the last denosumab dose would be appropriate. As mentioned, for patients at very high risk, it's recommended that osteoanabolic therapy be the initial treatment. These drugs, of course, are more expensive, and so it's important to consider the justification for that recommendation. First, as I've mentioned, only osteoanabolic drugs are capable of restoring the disordered architecture that characterizes osteoporosis, something that our anti-remodeling drugs do not do. Secondly, the bone density increases with osteoanabolic drugs are larger and faster than we see with anti-remodeling drugs. More importantly, we have head-to-head studies documenting the superiority of osteoanabolic drugs over bisphosphonates and over denosumab in terms of fracture risk reduction. So clearly, osteoanabolic therapy as the initial treatment is more effective than osteoanabolic drugs. Importantly, the fracture benefit afforded by the short course of anabolic therapy persists for at least 2 years after transition to an anti-remodeling drug. That was shown in the ART study, where patients for the first year received either alendronate or romosozumab, and at the end of that year, the patients on romosozumab had a lower fracture rate than the patients who received alendronate. After that 1-year time point, all patients in both treatment arms received alendronate, and the difference in fracture rates seen during the year of anabolic therapy persisted for an additional interval of time while everyone in both groups was receiving alendronate therapy. And lastly, I've mentioned already that if anabolic drugs are used after an anti-remodeling drug, then the bone density response and probably the fracture risk reduction is less than we see if the drugs are used as initial therapy. So if we want to take advantage of the superiority of an osteoanabolic drug, it should be given as the initial rather than as follow-on therapy. So osteoanabolic drugs are the most effective strategy we have, and the sequence of an osteoanabolic agent followed by an anti-remodeling drug is the most effective treatment for osteoporosis. Then we can maintain that benefit with anti-remodeling drugs used intermittently that I'll explain in a moment. If cost was not an issue, all patients with osteoporosis who are at high risk of fracture, not only those at very high risk, in my opinion, would be candidates to receive an osteoanabolic agent as the initial treatment to optimize bone mass and strength, and then we could keep that better bone for the remainder of the patient's treatment life with our intermittent bisphosphonate therapy. So no matter what initial course of therapy we use, whether it's a bisphosphonate, whether it's denosumab followed by zoledronate to consolidate the gain, or anabolic therapy followed by an anti-remodeling drug, ultimately patients achieve a steady state, and I believe transition at that time into what I call maintenance therapy. So to distinguish osteoporosis therapy from maintenance therapy, let me make these points. Osteoporosis therapy is where we first see a patient and we do our best to optimize and improve bone mass and bone strength to reduce their fracture risk. Maintenance therapy then takes the patient where they are, hopefully, after that improvement, and employ therapy to simply maintain that benefit for the remainder of a patient's life. We have evidence that we can do that. Shown on the left is a study I was involved in many years ago where we gave women in relatively early menopause with low bone mass either alendronate or placebo for 2 years. Then treatment was stopped, and the improvement in bone density that was seen with alendronate persisted for the 3 years while they were off therapy, while the placebo group, of course, continue to lose bone. On the right are shown data published earlier this year from colleagues in New Zealand, where they also treated younger postmenopausal women with low bone mass and gave them 1 dose of intravenous zoledronate every 5 years and followed them for 10 years, demonstrating maintenance of bone density while the placebo group lost over that interval of time almost 8% of their bone density. And this strategy was also associated with a 40+% reduction in fracture risk. So giving short courses of bisphosphonates intermittently is what I describe and define as maintenance therapy. So for patients who have, no matter what their previous therapy is, once they're ready for maintenance therapy, receiving alendronate for 2 years and then off for 3, and then repeating that cycle for the remainder of a patient's life is one strategy, or simply administering 1 dose of zoledronate every 5 years. One could monitor the patients and determine the interval at which you restarted the next course of bisphosphonate based on changes in bone density, or one could simply have a 5-year interval and re-administer the drug every 5 years. Of course, if the patient's situation changes, if they have a fracture, if they develop new medical problems, if they begin glucocorticoid therapy, then of course we would revisit the question of therapy and start over again. The strategy of intermittent bisphosphonate therapy could also be used in a program of prevention if we employed menopausal hormone therapy at the time of menopause to protect them from the rapid loss that happens across the menopausal transition. At some point, we could discontinue estrogen and then have the patient transition to maintenance therapy to maintain the benefit that the preventative therapy provided. So no matter what the patient's risk of fracture, no matter what their bone density, no matter what their previous treatment, the final phase of any osteoporosis management plan, I believe, is the maintenance therapy approach. If I were in charge of deciding and recommending how to manage patients, I would divide patients' fracture risk into these 3 categories: low, moderate, and high, For women who are at low current risk, but who are at high risk for developing osteoporosis, for example, women coming to menopause with low bone density with a T-score of -1 or lower, then I would consider menopausal hormone therapy or low-dose bisphosphonates, followed then by maintenance therapy. For patients who are at modest fracture risk, a 65-year-old woman with a T-score of -1.8, one might consider simply beginning intermittent bisphosphonate maintenance therapy with every 5 years alendronate in such patients. But for all patients who are at high risk of fracture, not only those at very high risk, I believe that we should consider optimizing their response to our starting therapy by beginning with an anabolic drug followed by an anti-remodeling drug. So in thinking about managing patients with osteoporosis, we need to think about not only starting therapy, but considering a life plan for osteoporosis management, recognizing that management requires long-term therapy. The management should be simplified based upon evidence of optimal therapy. We should start with our most effective therapies and then maintain that benefit with intermittent bisphosphonate therapy. And I believe that more attention should be paid to preventing transmenopausal bone loss in women who are at high risk of fracture. There is no single optimal treatment strategy. Management must be individualized with shared decision making. And hopefully, with that approach, we can help prevent the development of osteoporosis as depicted in the picture there on the right. Remember, as we make decisions about osteoporosis management, that we are not here to treat osteoporosis, we are treating patients with osteoporosis, and keeping the patient front and center in our consideration will make our decisions be more appropriate. Thank you very much for your attention, and like the others, I look forward to the discussion section. Thank you very much.
Thank you, Mike, for this comprehensive presentation. It was very clear. But anyway, we have time and a lot of questions from the audience. And I will start with the chat. I want to remember the audience to make in Spanish or in English your question. And I have some questions. Maybe the first is about drug holidays and how to manage the time of that drug holidays.
So again, as mentioned, drug holidays are appropriate for patients who have been on a course of a bisphosphonate and who, after 3 to 5 years, no longer meet the criteria for being treated by being at low risk of fracture. So with alendronate as the example, patients could discontinue therapy for perhaps 2 or 3 years, and then, assuming they are at low risk of fracture, they would be candidates for the intermittent bisphosphonate therapy. And so they could then receive a 2-year course of alendronate every 5 years, or 1 dose of zoledronate every 5 years after that. For patients who, again, after a course of bisphosphonates remain at high risk, I believe that switch to a different therapy, either to denosumab or to an osteoanabolic drug. As I mentioned and tried to emphasize, continuing bisphosphonates for more than 5 years does not improve the patient's fracture risk or skeletal health, but exposes them to the risk of atypical fracture. And we know that the risk of atypical fracture decreases quite markedly in the first 2 years off therapy. So that's why I think that no patient should receive bisphosphonates continuously for more than 5 years at a time.
And do you think there is an utility of bone turnover markers for that?
I have not found bone turnover markers helpful in individual patients. We monitor bone density, but in the maintenance therapy phase, the bone density should be measured very intermittently. So we, of course, monitor them at the beginning. After the 2-year course of alendronate, I would measure it again to reassure us that alendronate has maintained their bone density. And then, based upon all of the evidence we have, we know that being off therapy for 3 years is probably appropriate. And then one could simply repeat the alendronate, or you could use bone density and wait until you saw a decline in bone density before making that decision.
Thank you very much,
Okay.
Mike. Yes, well, thank you very much. We have a lot of questions here. Would like to start with this one. If not for cost, why couldn't everyone get Evenity first?
I agree with that and said that. So certainly, because the step therapy idea that we use in diabetes and hypertension does not work for osteoporosis drugs, but we should take advantage of the bone building effect of anabolic therapy as the first treatment for people who have osteoporosis and who are at high risk of fracture.
Thank you. I have another question here. It is very clinical, very important, I guess. A patient who received 6 years of denosumab, then she had a fracture in 2 vertebrae, and then she went to romosozumab. Now, after 1 year of romosozumab, with drug do you recommend to continue?
I don't know about that specific patient, but at the end of a course of romosozumab, I make 3 decisions, and I base that on the patient's total hip bone density. If the total hip bone density is already at a good place, that is a T-score of -2 or better, then I'm comfortable transitioning the patient to a bisphosphonate, because then, as Dr. Libinati pointed out, switching to a bisphosphonate maintains that bone density. If their hip density is not as high as I want it to be, I would choose denosumab to follow on because there is an additional increase in denosumab. And thirdly, there are some patients who at the end of a course of romosozumab, I know I want to do it again, another course of anabolic therapy. And for those patients, I would not choose denosumab because the transition from denosumab to romosozumab results in very little additional benefit.
Okay.
In those patients that I want to treat with romosozumab again, I give them 1 dose of zoledronate at the end of the course of romosozumab, and then 9 to 12 months later began the next course of romosozumab, and then of course have the same thought process at the end of that course.
Thank you.
I have another question. What should be the treatment for osteoporosis in a patient who reports having a bone pathology in the lower jaw? And how do you deal with the dentist also?
Not very effectively. The whole story of osteonecrosis of the jaw and its concern, of course, is a big problem. And I refer the dentist to the position statements of both the American Dental Association and especially the Oral Surgery Society that outline very clearly that if a patient is on a bisphosphonate and needs to have an invasive dental procedure, that there is no benefit in stopping therapy. There's probably no harm, but also no benefit. However, if the patient is on denosumab, we should not stop therapy because of the increased risk of vertebral fracture that happens if therapy is stopped, as Dr. Libinati outlined. And the Oral Surgery Society suggests that the invasive procedure, a tooth extraction or dental implant, be done 3 to 4 months after the dose of denosumab. Ideally, then the lesion will heal before it's time for the next dose of denosumab, and treatment does not need to be delayed.
Okay. Here's a very nice question, I guess. Can we use ibendronate for maintenance therapy?
No one has studied that, and I think not. The off effect of both residronate and abandonate is much faster than it is for either alendronate or zoledronate. So I think we need to take advantage of the very slow off effect of the longer acting bisphosphonates rather than using abandonate or residronate.
Thank you. And
In
there's a
the same time, it's what is the criteria for maintenance? A T-score?
yes.
Yes, we're I mean, bone density is the best thing we have to measure. That is the marker of whether bone loss is occurring. It's the bone loss that that we can observe that results in the deterioration and the damage to the architecture and the structure and the strength of the bone. So if we can maintain bone density, then I believe we are preventing the worsening of the skeletal problem and are preventing osteoporosis from happening.
Here we have another one. Would you consider repeating courses of osteoanabolic drugs, and how long after the initial course?
Yes. So with romosozumab, we know that we have to wait at least 3 months before beginning again in order to have the anabolic effect be seen again. So the background, of course, is that for all of the osteoanabolic drugs, as bone density increases, there is an upregulation of other inhibitors of bone formation, like DKK1, that inhibit the osteoanabolic effect of our treatment. So that's why we can only use them for a relatively short time. So with romosozumab, we know that being off therapy for a year is long enough for the anabolic effect to be seen again. And probably the same would be true for the PTH drugs. So, yes, we certainly should consider repeat courses of anabolic therapy if at the end of the first course the patient still meets the criteria for receiving those drugs.
And in the same topic, after completing 1 year of romosozumab, is it possible to continue at the immediate time with the teriparatide?
It's a very good question, and the answer is clearly no. So many
Why
of us
not?
many of us predicted that based upon the differences in the mechanisms of action. So PTH drugs like teriparatide activate primarily remodeling-based bone formation, whereas romosozumab increases both remodeling-based and, importantly, modeling-based formation. So romosozumab turns on bone formation everywhere. And once that's happened, there's nothing left over for teriparatide to do. So many of us predicted that. Real world studies from Japan have shown that if patients transition from romosozumab to teriparatide, nothing happens, and in fact, bone loss happens. They don't get better. The opposite is not true. Switching from teriparatide directly to romosozumab results in an increase in bone density in both the hip and especially in the spine. So that it's important, based upon the differences in the mechanisms of action, to make the right choices about transition.
Mhm. Here's a very practical question. When do you select romosozumab or teriparatide?
Yeah.
How do you select?
So there are two head-to-head bone density studies that were done. One is our phase 2 study that was published in the New England Journal in treatment-naive patients, and the other was the structure study, where patients who had been on bisphosphonates were then randomly assigned to receive either romosozumab or teriparatide. In both studies, the increase in bone density was larger and faster with romosozumab than with teriparatide. And if you believe then, as I mentioned, that on treatment bone density is important in correlating with fracture risk, then I would most often choose romosozumab. Furthermore, the course of romosozumab is only for 12 months, and the bone density increase is greater in that 12 months than it is with 18 or 24 months of teriparatide, making it less expensive. And lastly, there is a large observational study from Japan showing that fracture risk is reduced more with romosozumab than with teriparatide. So there are very few situations where teriparatide would be the first choice. Perhaps the one example would be in patients on glucocorticoid therapy, where we know that teriparatide is very good at protecting those patients from vertebral fracture risk, and we don't yet have that information with romosozumab.
I have another one here. In a very elderly patient over 90s with a new diagnosis of osteoporosis, what consideration do you take to decide the treatment?
Now that's a very important question, and as I approach 90, I'm more interested in knowing the answer. So I think the most important thing is what the health of the patient is. If he or she is still active and vigorous, and then treating their osteoporosis and reducing their fracture risk is very important. The the consequences of a hip fracture or a spine fracture in patients in their 80s and 90s is much more serious than if those fractures happened in younger people. So for uh, for uh, otherwise healthy elderly people, I think they are the ideal people to treat. Of course, if a patient is near the end of their life, if they're bedridden, if they have marked dementia or cognitive effects, you have to take all of that into account, and perhaps treating osteoporosis is not so important in those patients with other problems.
Thank you. Here's another question about, could you please comment some about the comparison from DEXA or REMS?
Yeah, that's an important question. I don't have personal experience with RIMS, but in the studies that were done mainly by the Italians and Europeans, and more recently by colleagues in Brazil, it appears that the correlation that RIMS provides a DEXA equivalent T-score. Of course, the answers that you get from a RIMS ultrasound tests are very different. The answer is not grams per square centimeter like it is in DEXA, but they have uh, made the calculations and correlations so that the result that's received is equivalent to the T-score from DEXA. So it appears that that is a very reasonable thing to do. And in places where DEXA is not available, of course, RIMS is more portable, is less expensive. It has ultrasound, not radiation. So there are several advantages of RIMS in certain situations and populations.
Thank you.
I have a question. It is my question. Do you have some comments about off-label indication of maybe teriparatide before surgery for spine surgery?
Spine surgery? Yeah.
Yes.
Again, I'm an endocrinologist, not an orthopedist, but my orthopedic colleagues in both my country and especially in Asia are very enthusiastic about the use of osteoanabolic agents for pre-surgery bone optimization. And the small amount of data that has been published about teriparatide is very promising, with a reduction in failure rates for spinal fusion surgery, uh, uh, decreased failure rates for hip and knee implant surgery. Uh, when I was recently in Korea, the orthopedists there are using romosozumab routinely before orthopedic surgery. They've not yet published their results, but at least their personal testimonies suggest that there's a very good response by rapid increases in bone density. So they treat patients for at least 3 months, if possible, if there's not an emergency for the surgery, and perhaps 6 months, even better, ideally, before the spine surgery is done. And that they claim that outcomes are much, much better.
It's promising. Yes. Thank you. And at the same time, for treatment for osteonecrosis of the jaw, do you have some experience with teriparatide maybe or
Yes, yeah.
abalotoparatide?
So for patients who need more than just conservative management, giving teriparatide appears to hasten the healing of O&J.
Mm.
So that's now done routinely in patients who require surgery or who have the more severe forms of O&J. And then, of course, if a patient is on a bisphosphonate, it's easy to discontinue the bisphosphonate, treat them with teriparatide, but then you have to decide what to do at the end of the teriparatide dose. If they've been on alendronate or zoledronate, probably, as we talked about with maintenance therapy, after teriparatide, one doesn't need to do anything for a while and make sure that everything is healed and fine. And then ultimately, they could be on maintenance therapy after that. If a patient's on denosumab and
Mm.
has O and J, you can't simply stop. But there is experience with adding teriparatide therapy to ongoing denosumab with the idea that the teriparatide will help with the healing of the O&J. And after the O&J has healed, then the teriparatide can be stopped while the patient continues on denosumab.
Okay.
Thank you.
Here's another case of another patient with 8 years with denosumab, but no increasing on BND. Then what drug to continue? Which one to continue?
Well,
Romosozumab or
so in a patient who's been on long-term denosumab, you cannot simply switch to teriparatide. That teriparatide does not inhibit bone resorption and so cannot blunt the rebound and remodeling that happens when teriparatide is stopped. We have very little experience with switching to romosozumab after long-term denosumab. After short-term denosumab, 1 or 2 years, then it appears that most patients do not have the big rebound in remodeling. But after 8 years of therapy with denosumab, I would go through the algorithm that I described and have the patient transitioned first to zoledronate and have zoledronate used for at least that first year to inhibit the rebound in remodeling. After that, then you could choose either teriparatide or romosozumab for therapy. So unfortunately, switching directly from denosumab to an osteoanabolic agent is not a good strategy.
thank you.
I'm so happy there are so many questions.
Yeah.
Yes.
So, but by the way, I put my email in the chat and anticipating that we would not get to all of the questions. So, for those of you who have questions that aren't answered, if you will send me an email, I will attempt to answer it. Not today, but over the next several days anyway. So, as Pilar and Claudia know, I'm on vacation in
Yes.
Yosemite National Park. So the answer will not come today.
But anyway, thank you for that. There is another question about the concern about the renal function for the use of teriparatide or romosozumab.
Boy, dealing with people with end-stage renal disease is a very tough situation with which we have very little data. So but I think an anabolic drug is more appealing than an anti-resorptive drug in those patients. I worry about adynamic bone disease. That's the worst form of renal osteodystrophy. And so I attempt to avoid the use of denosumab in patients on dialysis. And if I have patients with hypertension or diabetes who are drifting toward dialysis, I will attempt to have them have one dose of zoledronate, even if their creatinine clearance is 15 cc's a minute. We give them one dose of zoledronate infused very slowly over maybe 2 hours, and that can be done safely in terms of renal function. And then, if they need therapy while they're on dialysis, then I think choosing one of the anabolic drugs would be my choice. And their previous zoledronate therapy will last for a very, very long time because of their impaired renal function.
Okay, thank you. Here's another question. If someone is using corticosteroid lifetime, then which therapy do you recommend?
Again, that's very hard. For patients whose bone density is low and who have had vertebral fractures already, then I think, as I mentioned, one of the PTH drugs is really good. So I frequently treat patients with teriparatide for 12 or 18 months, and then I follow that with a bisphosphonate like residronate for 6 to 12 months, and then treat them with teriparatide again. So, uh, 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 at least in my country, dealing with the insurance companies and reimbursement, of course, is a big problem. But we have to explain to them why that's important. So I think again, because the underlying pathophysiology of glucocorticoid-induced osteoporosis is primarily an impairment of bone formation, then a bone-forming drug is actually the best management rather than long-term bisphosphonates or denosumab.
Thank you. If you have the opportunity to choose between teriparatide or abaloparatide, which one do you select?
I think there's very little difference. There may be a slight advantage efficacy-wise with abaloparatide.
Thank you.
United States, abaloparatide is less expensive, and so we frequently make the choice to use abaloparatide based mainly on cost.
Is there more different in the bone density or hip bone density? Do you
No,
think it's important? No.
minimal. So the difference in the studies was that there was a slightly better reduction in non-vertebral and clinical fracture risk with abaloparatide compared to teriparatide. That difference was not statistically significant. It all happened in the first few months of treatment, the difference did. There was a statistically significant difference in the reduction in major osteoporotic fractures, better with abaloparatide than with teriparatide. But all that was a post hoc analysis of a small number of patients, actually.
Okay, thank you.
Here's a very important question, I guess. Do you use the same treatment protocol for younger patients with osteoporosis due to endocrine or other diseases?
For secondary forms of osteoporosis?
Maybe.
Maybe, yeah.
Yes. Obviously, if people have secondary causes or endocrine causes, you want to correct that, correct the hyperthyroidism or the Cushing syndrome. That's important to fix that. But the management of the bone part of their problem is done very similarly to patients with postmenopausal osteoporosis.
Thank you.
There is a question, but maybe it's for another webinar.
Another time.
It's about the experience in osteogenesis imperfecta. Maybe it's too wide for
Yeah.
the term, but
Well,
some comments about that for the treatment?
Right. So the answer is different for children than for adults. For children, bisphosphonate therapy has been the routine, and mainly intravenous pamidronate has been used very successfully to reduce fracture risk. After puberty, fracture rates in patients with OI go down, and there the studies that my colleague Dr. Orwell did with teriparatide are very interesting, where there's a bigger increase as expected with teriparatide than with alendronate. So again, I would be very cautious about the use of continuous bisphosphonate therapy in those patients. So I think a course of teriparatide or maybe romosozumab. The studies with anti-sclerostin therapy are underway, but we don't have those answers yet. And so for adults with OI, a course of an anabolic drug followed then by the intermittent bisphosphonate therapy, I think would be appropriate to consider.
Thank you.
Cool.
Here's a question that maybe we can use as a closure because our time is almost done. It's about if you have the three choices, denosumab, teriparatide, or romosozumab, which one goes first?
Romosozumab.
Oh, that was very short, short answer.
No, there's no question. You certainly would not use denosumab if you expect to use either teriparatide or romosozumab. And if you use romosozumab, then I don't see very much benefit in considering teriparatide. So if I want another course of anabolic therapy after the first course of romosozumab, I would choose romosozumab again rather than teriparatide. So romosozumab followed by denosumab is clearly the most effective sequence that we have if we're only going to use two drugs.
Thank you very
And
much.
in the same idea, how do you decide that Romo is safe looking for cardiovascular risk?
Okay, but again, that's a subject for another lecture. I have just written.
Sorry.
I've just written a clinical perspective that has just been accepted in JBMR, so it'll be put online within another week or so. That outlines and describes that in great detail. But that's a subject for a longer conversation.
We have to read it.
We have to invite you again.
Good. That'll be good.
Thank you. Thank you very much. So maybe,
Okay.
Claudia, yes, we have to close.
Yes, we have to close. There is still some question, but we will send to Mike by mail. And we want to thank you so much because we know you are on vacation, so it's very kind to be here. So thank you for all the audience. It has been a very good conversation. I think the best part is the question part. So I'm very happy.
That's always the best part. Right.
To have the opportunity to participate in that. And for the closure, I leave with Pilar.
Thank you. Thank you very much.
Thank you all.
Yes. Thank you, Claudia. Thank you, everyone. All the audience, you were fantastic. And Mike, as always, your talk was fantastic. So thank you all. On behalf FELAEN and on behalf ISC, I just want to thank you, everyone. And very soon we are going to launch our 2026 program. So to invite you all. Have a nice weekend and enjoy your vacation.
All right. Bye all.
Bye-bye.
Bye all.